Hi everyone. This is our last module for CP 600. I'm hopeful that the class format has been meaningful and useful for you all, and I look forward to hearing your feedback at the end of the quarter. During this module, I'm going to discuss chapters 7, 8, and 9 of the Steiner text, and then chapter 14 from the Brems text. First, in chapter 7 of the Steiner text, the authors discuss difficult medical issues that impact adolescent clients and may bring them to your door. Chronic illness is complex. Whenever a person is diagnosed with a chronic illness, it is important for him or her to find ways to manage their illness, assume this new label into their identity, and adjust their daily life accordingly. This type of change is stress-producing for the person with the illness and for that person's family system. When a teenager has a chronic illness, then the normal developmental trajectory might be altered, and he or she might respond to their illness in a number of ways. In your text, the authors discussed a number of different problems that medical professionals might encounter in their work that could lead to a referral for mental health treatment. In this chapter, the authors are speaking from their experiences within the medical model of helping. Much of this information may feel redundant for you. I did include a link for updated information regarding mental health care under the new Affordable Care Act, or Obamacare. Your hyperlink on this slide will take you to a short article regarding the treatment of adolescents with a chronic illness. As you can see, this is about 6% of our youth. If you're planning on working with children and adolescents, then you may have opportunity to do some of this work. If you do have opportunity to work with a client who has a chronic illness, be aware of the impact that their illness might have on their development. One thing that I've learned from living with a chronic illness myself is that sometimes I have to grieve losses. Your authors refer to these as crisis points. For me, whenever a new symptom develops, then I am faced with adjusting my expectations of myself to meet my new functioning. Most recently, I had an episode of optic neuritis. During this exacerbation, my vision in my right eye was impacted. I couldn't see well enough to drive, and at the time I was doing outreach case management. I had to ground myself and work from a desk for a few weeks. My clients and I adjusted to the temporary change in circumstance. Privately, I experienced a good amount of fear because of the uncertainty with not knowing how long the exacerbation would last and trying not to catastrophize. In your clients, you might be sensitive to the ways that their illness impacts them as a member of their family, but also the ways that it impacts their private selves. Mental health issues likely affect about 20% of medically ill adolescents, according to the chapter author. The co-occurrence of medical and psychiatric conditions might impact disease management, and the symptoms of a psychiatric illness might mimic those of a medical illness. Mental health workers are frequently utilized to assist adolescent clients with co-occurring medical and psychiatric illnesses for a variety of reasons, such as pain management and relaxation training. As you can see on this slide, it will be important to approach treatment from a stance of collaboration. Remember to meet your clients where they are and respect their person. There's a good chart on page 283 in the Steiner text that lists a number of cognitive behavioral techniques that you could use with these clients. This is also a good general list of different CBT strategies. On slide 10, I've linked an informative article on childhood and adolescent somatization. Here on this slide, I've highlighted some changes made to this category of disorders in the new DSM-5 and listed a few ways that somatization might begin for clients. In the new DSM, factitious disorders are included in the chapter on somatic, symptom, and related disorders. The hyperlink on this page will take you to an overview of factitious disorders. You may have heard this particular disorder referred to as Munchausen syndrome. This name came from the Baron Munchausen, who was a German nobleman in the 1700s, who created fantastic tales about himself. These were later published as The Surprising Adventures of Baron Munchausen. This is a rare disorder and difficult to diagnose. Most often, the disorder begins in early adulthood. In children and adolescents, factitious disorder imposed by another person might be more common. In Chapter 8, Thienemann and Shaw discuss adolescent onset schizophrenia and other psychotic disorders that manifest during this time period. Early onset schizophrenia is typically associated with a poor prognosis. I'm reminded of a young client, Abdul, that I worked with. He was 18 whenever I knew him. This young man grew up in Somalia and was a refugee for a time in Nigeria before coming to the United States. He lived with his family in a small apartment in South King County. He was detained and sent to Fairfax Hospital after the police found him walking naked down Pack Highway, claiming to be the Son of God. He began outpatient treatment after his discharge, and I was his assigned caseworker. His family was close-knit, and their support of Abdul was apparent. Unfortunately, as his acute symptoms abated, he became less and less willing to take his medication. Despite our efforts, Abdul had a second psychotic episode, and this time he physically threatened his mother. These cases are incredibly difficult to witness. Whenever you work with adolescents with schizophrenia, please remember that this is an organic brain disease. The behaviors that you see, such as walking down a busy highway claiming to be deity, are nothing more than symptoms of this illness. Counseling is important, but it is not a standalone treatment here, as medication is critical to future prognosis. Here I've included updated changes in the DSM-5. The chapter authors discussed diagnostic criteria, and accordingly I thought I would include this information as it reads in the new DSM. One of the biggest changes to schizophrenia is the elimination of the subtypes. The symptoms are still the same, and the diagnostic criteria are virtually the same too. You guys know that the symptoms of schizophrenia are classified as either positive or negative. Positive symptoms are behaviors that are not seen in healthy people, such as delusions, hallucinations, and disorganized speech, whereas negative symptoms are those that indicate a disruption to health functioning, such as blunted or flat affect, an inability to form meaningful social relationships, impoverished speech or thought, and a general lack of motivation. Many times, clients with schizophrenia need help with the very basic tasks of daily life, such as hygiene and meal preparation. In addition to a diagnosis of schizophrenia, psychosis may be a feature of other illnesses. I've seen psychosis associated with bipolar disorder. There's a story I can tell you guys here in class. Will you remind me to do that? Also, schizoaffective disorder is a rather common illness in community mental health too. Whenever you sit down with an adolescent who is experiencing psychosis, remember that the client is not thinking clearly, and he or she might feel quite vulnerable even though they have difficulty expressing that in a coherent way. Most people with schizophrenia are not violent. If they do behave in aggressive ways, it is more often aggression towards their own person rather than towards others. Still, it will be important for you to have some support while you sit with these clients. Make sure members of your team are aware of your appointment and can be available if the need arises. In all of my years of working with severely mentally ill clients, I can recall only 2 times that I ever felt scared that a client might act aggressively towards me. As you guys know, working with these clients is where my heart lies. I would really encourage you all to deconstruct whatever stereotypes or assumptions you have about working with people who are schizophrenic. This group has been marginalized to the point that we treat them as if they're invisible members of our society, and you can see evidence of this anytime you go to downtown Seattle and encounter the homeless population. Please pay attention to the language that you use. I've heard my students use terms like schizo to describe a person. This is inappropriate and pejorative. As a professional, you need to speak in ways that support your clients. Use people-first language, such as a person with schizophrenia, or use the diagnostic label as an adjective, such as a schizophrenic client. I hear the same sort of pejorative language when we talk about clients with borderline personality disorder. Calling a person a borderline is inappropriate and pejorative. I want you all to take those words out of your vocabulary, as you are mental health professionals now. Psychosis is an organic disorder and will require medication to control. Here you can see a few tips that your textbook authors provided in this chapter. When working with adolescents, remember that psychosis that presents at an early age will impact cognitive development and capacity. In addition to cognitive difficulties presented by psychosis, the medications that we use to treat psychosis are serious drugs with a complex array of possible side effects. The newer antipsychotic agents, or second-generation antipsychotics, address many of the historically relevant symptoms, such as tardive dyskinesia, but they present a new side effect profile. I know the print on this slide is small, but the last bullet point will take you to a short article on side effects of second-generation antipsychotic medications. In addition to medication, adolescents with schizophrenia and other psychotic disorders will benefit from individual therapy, family involvement, and group therapy for social support. Because psychosis can be so debilitating, many times agencies will offer day programs and even residential treatment for those that are severely ill. An early diagnosis of psychosis or schizophrenia does not typically bode well for a person. As you can see in this quote from NAMI, early intervention may reduce the decline in functioning that accompanies schizophrenia. In the final chapter of the Steiner text, the authors introduce trauma and pathologies that can develop out of trauma. Abuse and neglect are far too common in our culture. Often, chronic exposure to traumatic events will result in physiological and psychological changes to a person. In its most severe form, these changes are called post-traumatic stress disorder. PTSD in children and adolescents may manifest in ways that we don't see in adults. Adolescents take risks. This might lead to a traumatic event, such as a car accident after drinking, that could later surface as PTSD. Adolescents respond to stress in unique and different ways. We may not always see these, and adolescents may not always tell other important adults what's happening for them in their private lives. We talked about the historical roots of trauma in our class on trauma and violence, so this is just a brief refresher of where the study of trauma began and where it is now. I'd be happy to spend more time on this in class if you all are interested. In the newest DSM, there's a chapter devoted to trauma-related disorders, and these are listed here. Your hyperlink here will describe the changes to the DSM regarding trauma disorders. In light of repeated exposure to traumatic events, some people may develop symptoms of borderline personality or antisocial personality. Dr. Stephen Porges, that's Porges, has studied extensively the role of our nervous system in responding to stressful events and has outlined the polyvagal theory to describe some of the physiological changes that can occur. I think I'll spend some time with you talking about trauma next week. In addition to changes in a person's personality structure, many individuals that experience acute traumatic events may develop what is known as survivor syndrome. Check out the link here for a little more information. Your chapter authors did offer some useful tips regarding working with individuals who have experienced trauma. This is another area that we've covered in other classes and even spoke to earlier in this course. There are a number of treatment strategies that can be used in treating trauma. Some of these are listed here. Pay attention to the list of medications. Some of these are not what you might expect. For example, propranolol is a beta blocker that is often used to treat high blood pressure, and it's also used off-label to treat neurological symptoms such as tremors. In the trauma population, there have been surprising results regarding propranolol's ability to mitigate the impact of intrusive memories. When you begin your internship, you will encounter clients who have experienced trauma. I want you all to develop rituals for self-care. We will talk about this a lot during internship. This is not easy work, but it's powerful work. The most important lesson I have learned from clients who have traumatic histories is exactly what Dr. Herman says in this quote. Bearing witness to another's experience is therapeutically powerful for the client and for you. This last chapter in the Brims is relatively short, so I'll speak briefly to that content here. In this chapter, Brims discusses termination with children. I'd say that her chapter here is relevant regardless of the age of your clients, although she does provide some useful age-appropriate suggestions too. In the real world, termination rarely happens as you might have planned. Most often, clients are lost to contact or moved to a different area. In many therapeutic relationships, termination might be initiated by the clinician. I've had to do this on occasions when I was changing jobs. There are also reasons for termination that might exist outside of the therapeutic relationship. Maybe the agency is closing down, or a child's parent is taking a job in another city. Premature termination is more common than natural termination, in my experience. Natural termination is the ideal, however, and you can see some of Brims' reasons for the natural termination here. Now, this was an interesting section to me, to see the different signals that a child client might present that could signal an ending to the therapeutic process. As you all know, my therapeutic work with children was in the context of a domestic violence shelter, so I didn't have relationships that ran their course in the traditional way. In those cases where you have the luxury of experiencing the natural ending of a therapeutic relationship, Brims offered suggestions for how to prepare yourself, the client, and the client's family for this event. Brims also offers guidelines for assisting the client through the process of termination, and she likened the process to the stages of grief. In those events that termination is premature, you can pay attention to the same process that Brims outlines for natural termination and make adjustments to meet the needs of the client. All right, that's it for our lectures. In class next week, I plan on having activities that will supplement our readings regarding dealing with trauma in child and adolescent populations, understanding psychosis in adolescents, and one final role play. We'll see you soon.